Okay, let's go. So,
Okay.
before beginning with the speech entitled Clinical Trials Data for DCB, I would like to thank the GIS Organizing Committee for having me in front of such a distinguished audience. And as a high-volume CTO operator with more than 400 cases since the beginning of this year, the topic will be handled from a complex PCI and CTO perspective. We need better solutions than stents in complex and CTO PCI. Stent ender expansion, malopposition, stent thrombosis is still a problem despite the increasing use of IVUS, atherectomy, and IVL. So another problem we are facing is the need for long-term dual antiplatelet therapy, which increases the risk of intracranial bleeding and mortality in elderly patients. So the rising interest of leaving nothing behind concept cultivates hope for DCBs. The DCB topic will be handled, examined, and under these 5 subheadings with the very latest publications. So here comes the latest ACG guidelines. The ACG guidelines changed its recommendation in in-stent restenosis and states that DES is recommended over DCB for treatment of in-DES restenosis. Behind this decision-making lies three studies. The first one is the Daedalus meta-analysis incorporating 10 randomized trials. In this study, target lesion revascularization at 3 years was higher with a DCB treatment of DES in-stent restenosis, while there was no difference in terms of safety endpoints. There was no difference in terms of MACE. The second evidence comes from the 10 years follow-up of the ESA Desired 3 trial, which indicates no difference between DES and DEB, in-stent restenosis treatment. The last one comes from a meta-analysis revealing the combined endpoint of 5 randomized trials. The common evidence of these 3 trials is that there is no safety difference in using DEB over DES in DES in-stent restenosis. So imagine this long lesion as an in-stent restenosis. Who would think up front stenting such a long lesion and hoping for a moderately better target vessel revascularization at 3 years? Personally, me not. Covering the artery with 2 layers of stent and damaging the artery's vasomotor function further by creating a stiff pipe, is that the answer, really? What if we have a re-in-stent restenosis after 2 metal layers, putting a 3rd stent? Is that the solution? So for me, it is not. So after I was long scoring an NC balloons in in-stent restenosis, and preferably with an NC drug-coated balloon, elating balloon, is my default strategy in in-stent restenosis. If we have a restenosis in 3 years again, all options are still on the table. What if we have restenosis in an area with an overlapping 2 metal layers? What option do we have then? Here, small vessel disease is another topic. Although we have plenty of randomized trials, no guideline recommendation unfortunately exists. A 2022 TCT report indicates no difference between DES and DEB in terms of target lesion failure and MACE at the 5 years follow-up of the RESTORE small vessel disease study. You can see at the Piccoletta trial here, after 3 years, less vessel thrombosis and MACE with DEB, with the Elutax DEB. And at the bottom we have 2 meta-analyses incorporating each of them 5 randomized trials, and they concluded less vessel thrombosis with DEB at 1 year. So let's go further here. Let's see what we have. Okay, so small vessel disease, this is in CTO as an example for DCB in the bifurcation and small vessel disease. We put a stent towards the diagonal and then treated the LAD as a side branch, and this is 2.5 LAD, and it was treated with a paclitaxel eluting stent, paclitaxel eluting balloon. So we have also evidence for de novo large vessels, and preserving left main from stenting in osteal lesions is also very appealing. Here we have an example. This was an elderly frail patient, 85 years old, with high bleeding risk, planned to undergo non-cardiac surgery, and the osteal LAD was the hitch here. So IVUS showed more than 270-degree calcium ring. We did first lithotripsy with the follow balloon, and we cracked the calcium. As you can see on the right panel, we have cracking, achieving, and then preparing the lesion further with a long scoring NC balloon. And here comes again the NC drug eluting balloon, 4.5 by 20 millimeter, and the same balloon was inflated 3 times at the same part, because this was an elderly patient, and she couldn't tolerate more than 30-second balloon inflation, and we covered the osteum completely in this case. And here you will see the final result. Come on. Okay, no, go. I have to do something here. Okay, so this is the final result. So let's go. Okay, this is another. This is another CTO lesion. This time it was an LAD osteal lesion, and we treat them further with DEB. It was a primal retrograde case, and we did a ping pong, and after ping pong, we prepared the lesion again with the scoring balloon, 3.25 wedge NC scoring balloon, and then we had again an NC balloon. I used the NC balloon especially in osteal lesions, in calcified lesions, and in instant restenosis. So this was 3.5 by 20, and we inflated this 3 times the same balloon at the osteum covering, protruding into the left main. So here is the final result. So another rationale is as the bifurcation. So the bifurcation lesions represents another attractive scenario for the use of DCB. Avoiding a 2-stent layer strategy by applying DCB on the side branch translates into a better MACE rates in these 4 studies here. So again, simulating this scenario in a CTO case. This patient had only a retrograde option here. I had only an antegrade option, but a viable LAD territory, and we had to, because it was viable, we have to knuckle down, and then you can see we stented the main LAD, and the side branch was treated with a DEB. So these are the here, and another topic is the last topic is the CTO, is my favorite one here, and in this trial here. The very latest publication indicates no difference between DES and DEB in terms of MACE, target vessel revascularization, and target lesion revascularization here. So, and as a progress CTO investigator, we are collecting our data. Use of DCB increased from 2018 to 2024 significantly, especially in the last 2 years. The increase is prominent. Here, these are the CTO scenarios, how we do the DEB in CTO, and here me and Ömer are the main investigators of an only DCB approach in CTO PCI. I think in the middle of 2025, we hope to give you some updated, fresh data about this topic here. So let me give you some examples. So this was a primary retrograde case, and after tip-in here, I skipped this one. Again, preparing the lesion with a 3.5 wedge NC, and then again with a Protege 3 by 30 at the distal part, 4 by 30 at the proximal part. What's going on here? Come on. Okay, they cut me off. Why?
Because time is over. So we, 5 seconds, or sorry, 30 seconds.
Give me 1 minute. I have to convey my
1 minute from my time.
Thank you. Okay. So I go a little bit fast then. So here, and this is the end result. We managed to do a no stent, but just drug-eluting balloon. And this was a live case again. And this was a hybrid approach. The proximal catheter dissected the proximal part, so we had to do a hybrid approach, and you can see the final result. And the interesting thing is we are collecting also and doing control angiography here. And after 4 months, you can see how the vessel has grown. And here is another case. It was a very calcified vessel. After WHNC and NC drug-eluted balloon, you can see the final result. And after 2 months, the result is still acceptable. I skipped this again. After 2 months here, a CTO, we have the vessel has grown. I'm almost done. This is the last case here. And here we have, okay, thank you.